Great. And so with that, I just want to welcome everybody to night 11 of our virtual series on trauma management, trauma nights coming at you from Motor as well as in association with COTS. As is a continuation of our ongoing series that we've, let me just, oh, I think I got the wrong presentation up here. Sorry, guys. Let me just switch out of that. Stop sharing for a second. And sorry about that, guys. Let me just get the correct one up here.
I see we have Dr. Stockton there and Dr. Perry.
Right on, we're getting some good
two residents in our program. It's Irene, that's great.
Well, what I'll do maybe is I had a slide here that's going to be pertinent, so I'll just go over to that one. And we'll just stay at that one. Sorry about that, everybody. So we'll just keep going. So I want to welcome everybody to tonight's session on pelvic fractures. This is, of course, a continuation of our three-month program looking at various different fractures. And part two of our specific series dedicated to pelvis and acetabulum. We, of course, had a night last week with Dr. Chip Rout, who went over a more general talk about approach and philosophy with pelvic and acetabulum. And we're excited to have two of our COTS experts in pelvis fractures join us tonight, Dr. Kelly Lefaivre, as well as Dr. Pierre Guy joining us from UBC, both very well known and well published and really respected members of our COTS community who are experts really in pelvis and acetabulum, and we're lucky enough to have them join us today. Dr. Lefaivre will be talking to us about management around LC1 fractures as well as some controversies related to those, and Dr. Pierre Guy will be talking to us about guidelines and BC guidelines surrounding pelvic management specifically. Myself and Dr. Siri will be our moderators for tonight. We're two of the faculty from MacOrtho and two of the pelvis and acetabulum group here. And Dr. Dan Axelrod, one of our residents who's been instrumental in making this series a success, will be giving us a case presentation to introduce the night for us tonight. So without further ado, I'm going to turn things over to Dan, and I'll stop sharing my screen and let him start sharing his.
Yeah, that's great. Thanks, Herman. So I'll just open up my PowerPoint. Does everyone see that blank white slide?
Yeah.
All right. So I don't know if there's anyone who wants to answer some questions about a pelvic trauma case. Otherwise, I can just kind of go through it. It's not like that there's all that many residents on, so I'll just get started then. So just to kind of frame the night, we have a 27-year-old male who's trauma activation. He was part of a car rollover. He was trapped in a prolonged extrication. He was hemodynamically unstable at the scene, and GCS was just moderately depressed. He had a binder placed after he was extricated, and the EMTs noted that his vitals improved. After arrival at the trauma center, he had balanced resuscitation protocols, and then his vitals continued to improve and stabilize. So the first image that we were given in the trauma bay was this, and is obviously a quite rotated film, and it doesn't give us all that much information about the fracture, but if you look, you can see there's a sacral fracture on the left. There's obviously a comminuted acetabular fracture, bilateral rami fractures, and then I'll go through the CT scan. This is the axials. Just kind of will scroll for about 20 seconds. So you can see that on the right, there's SI joint disruption. And on the coronals, you get a better appreciation of the acetabular injury. So to summarize, to add as well, this gentleman had overall mild other injuries. He had a closed head injury, which was did not require intubation. A closed left both bone forearm fracture, a small splenic laceration, which was sort of probably the cause of his hemodynamic instability as well. and he had L2 to L5 transverse process fractures. So to summarize the pelvic injury, an associated both column acetabular fracture. He also had a fracture of his AIIS, anterior inferior iliac spine. And from his pelvis perspective, he had a unilateral APC with an SI joint disruption and a left-sided compression with the sacral body fracture. I don't think there's any, I'm not sure there's any junior residents that are on the call, but just for the purpose of this, this is sort of a windswept pelvis type injury. So just to go over sort of how we manage this injury, I think it was just kind of interesting. We'll frame how we go about this talk later. We first addressed the right hemipelvis by placing a partially threaded cannulated screw to close up the right SI joint. Then managed the sacral body fracture on the left with the transsacral transiliac screw. Did an anterior intrapelvic approach to manage the both column acetabular fracture, and had this single partially threaded cannulated screw to help reconstruct the superior dome, which was a part of this AIIS fracture. And just looking at final images, you can see this sort of complex fracture can be broken down into its segmental parts. And there's usually a formula for how we approach these injuries. And I think in this circumstance, it works out quite well. And so this patient's now 2 years post-op. He's 27. He has no pain in his hip or his pelvis, and he's ambulatory as expected. So with that, I think we can turn it over to our experts. Thank you very much.
Thanks, Dan. That's a great case, a great introduction to Dr. Pierre Guy. Topic about the clinical practice guidelines and pelvic injuries. This patient had both pelvis and acetabulum, but we'll see what Dr. Pierre Guy going to give us today.
Yeah, and that's a complex case because it's got combined both pelvic ring injury and associated acetabulum fracture. I think Dr. Lefaivre will be joining us pretty soon. So I think maybe what I'll do is we discuss, I'll just go ahead and please let me know if you can see.
Yes, we can see this.
The presentation. You're happy with that?
Yep.
So, so thank you for the invitation, and very pleased to be able to join you tonight.
So hold on, right now, I think we're just seeing your PowerPoint panel. We're not seeing the slideshow.
Okay, good. We can solve that. I do this, and I'm going to show you this, and pick that. That what we did before. Why don't we try this? And now?
I think if you press on the slideshow on the top menu,
Oh.
and then gonna play after the slideshow.
Oh, my screen sharing is paused. I want to do that.
Yeah, I think there might be a panel at the top there. Just try sharing your screen again.
Display settings. How's that? No?
I think you just have to start sharing again.
Okay. Well, by the time we've got this down, so I picked the screen. That's what I did before. And good. And there, share. And you see my presentation now?
We see it in PowerPoint. Are you already in the presentation mode?
Let me get in presentation mode now. You see PowerPoint still?
Yes.
Okay.
Those resume slide. Okay. It always seems like they put the buttons
Just
in it.
tried it before we started, and that worked.
Yeah, it seems like the Zoom moves the buttons on you as we go.
Okay, let me get out of here and hopefully I don't log my.
We've got Kelly joining us. So, well, we're just figuring out Pierre's Zoom, but I think it was serendipitous that now left us time for Kelly to actually join us. So, and why don't we switch to her presentation, then we can transition to yours after, Pierre, if that's okay.
Yeah, sure. Either way, I'm just gonna undo the screens and it should be good. So,
I just need 1 second here to get organized.
No worries. Sorry about a little bit of a rush. I heard you were coming straight from the trauma room. Busy day.
Yeah. And I decided I would try and make it through traffic to my better setup for Zoom, and that turned out to maybe not be the best plan. Just give me 1 second here.
Sure. And just while we have a pause, one of the things I was going to mention at the start is next week we are taking a break for COA. So I encourage everybody to go to, there's a variety of different presentations at COA, and we have some of our organization committee here joining us as well. So we, there's going to be some COTS talks. Dr. Shemitz is going to be giving a talk, as well as Dr. McKee on soft extremity. We'll have a foot and ankle session as well. So hopefully I encourage everybody to look through the program and take advantage of all the great sessions. Would have been great to actually come out to Vancouver to join you guys though. Hopefully sometime soon.
I know, yeah, it's not quite the same to be hosting it when it's not actually in town. So Pierre, are you having any luck with your presentation?
I'm okay to go if you want.
Can you go ahead? I'm having a fundamental PowerPoint problem here. I can't get anything to open, so I need just a minute.
This is gonna go. This is going now?
That's working now.
Okay, perfect. Okay, so thank you for this this opportunity and for the invitation. I just need to acknowledge the Specialist Trauma Advisory Network in BC that brings all the specialists that take care of trauma patients, and the organization that funds all the this work. And if you want to look up this clinical practice guideline that we've developed for British Columbia, you can Google PHSA STAN, which is the Specialist Trauma Advisory Network, and then pelvis, and that will get you there. The idea initially was to talk about the management of hemodynamic instability and pelvic ring fracture, and we thought it was an opportunity to just guide the whole care of patients with pelvic ring injuries. So it brought together a number of orthopedic surgeons from all the regions across British Columbia. And of course, if we're going to talk about pelvic ring injuries, we have to bring in some specialists from general surgery, radiology, from urology, and then the team at Trauma Services BC. And disclosure from my point of view, we did receive the funding. I did receive funding for spending hours working on this guideline, and I chair a work group for quality improvement in BC that's relatively related. Unrelated to that, I have some disclosures, but they're not related to this topic in particular. So let's start with a case, because it's good to have a case. So you have a 62-year-old male, motorcycle collision, blood pressure 80/40, and he has an open wound over his pelvis. And then at this point, I don't know, can we use the chat? Is that enabled? Is that enabled for folks?
Chat's enabled, yeah.
Yeah, so what do you think he would need at this point? Do you think he needs to go to angio for embolization? Do you think he's got a bad injury in the front of his pelvis? He needs a retrograde urethrogram? He needs a CT cystogram? Does he need a pelvis binder? Or does he need to go to the OR to get pelvis packing? So maybe get some folks to answer that. I can't see the chat right now myself. So, oh, here we go, chat.
Yeah,
Some responses. So binder, you can answer either by text or by the number. I'll leave a couple people answer. So a lot of, so I'm very, that's good. We're very pleased to see that the binder wins, and it's certainly something that's very well known, if you like, in the probably in the academic and training environment, but it's not necessarily something that's known in the periphery and throughout British Columbia. But one of our guideline statements relates to that. So this is one of the steps in the care of patient with pelvic injuries, and that's was one of the goals, to identify some of these critical steps, and what I'm going to share with you as well. And then see also where the various specialties can be involved, and then at the end with this session, how people can integrate this CPG in their local trauma protocol. So of course, because it's it's a guideline, it's got to have a diagram that takes you one way or another, and that's been developed with in a multi-specialty environment, as I told you. As best we can, we made it evidence-based, but we also mindful of the various resources and locations in BC where patients can be injured. BC, as Ontario is, or in many places across Canada, is a wide territory, often just populated at the south. So we wanted to make it applicable to all clinical settings over the entire territory of BC. And it's structured in 11 critical areas and 6 key management questions. And we use the best evidence available, which mainly consists of level 4 evidence, I would say, and then and some the guidelines that were related to those. So the path is, or the guideline is broken down into different phases. So there's one that's just pure early resuscitation. The other one is a little bit more on the diagnosis. And then there's a big portion that's on controlling bleeding. In there, we also added the different areas that talk about transfer to higher level of care or transfers back to lower level of care. And then we tried to clarify at each stage where the local orthopedic surgeon should be involved in the development, in the care of the patients. So if we start back, with our first patient, they had to confirm the suspected pelvic ring injury, and say in this case they had a confirmed pelvic ring injury. Applying the binder, everybody did that. That's good. So massive transfusion protocol should be the next thing that's done. Given tranexamic acid, using a hemostatic resuscitation approach, and then moving on to imaging. The goal of the binder, as many know, would be to decrease the volume of the pelvis. So as you decrease that, you would have some sort of tamponade effect as the sheet would apply, whereas the definitive fixation would apply. You would have a reduction in stability of the volume. How does the volume work? So 2 larger studies based on that. These are all historical control. Both are historical control studies. One out of Hong Kong, one out of Denver, that identified a higher association with a decrease in mortality, but a higher associated with survival in the years that the patient had when the system had the use of a binder. Now, this was also done in the setting of transfusion protocols being improved, them developing a protocol at all. So it could be the effect of which could be multifactorial, but certainly the binder was one of them. Few notes about binder applications. So you need to be careful not to develop pressure points in areas where you apply your binder, and then make sure that the binder is actually effective. Kid you not, these are cases of patients who are transferred with the idea that a pelvic binder had been applied to their pelvis. The way to apply a pelvic binder has been well described, so it needs to be applied in the correct position. So trochanteric position should be used. And I would consider that at least a 3-person task. So having the patient lying on a sheet, applying a traction to the limb that's involved. If it looks like they're shortening, applying some internal rotation, and then sequentially placing the binder over and placing clamps over the area. Could also be done with a commercially available binder, again, inline traction, internal rotation, and applying the binder. What to do after the binder is applied? We'll actually need to rule out if a missed pelvic fracture has occurred. So this actually has been described out of Bristol. So although this X-ray might look very good, and the CT scan also looks very good, they identified as much as a 7% displacement of patients with the pelvic ring injuries when they took off the binder. So something to take into account. A complete physical exam and assessment of the patient for all the systems that are involved around the pelvis. So neurovascular, of course, but GI, GU is really critical. Looking for any open wound is really key. If we scroll down the protocol, you can see that as the patient is being assessed, they might require transfer to a higher level of care. And then we'll go into the situation where the person is hemodynamically unstable to the bottom right of our protocol. And then we identify if the person's a responder or not. So give you a different scenario. Young male in his 20s, he complains of abdominal pain, heart rate is 120, BP 80/40, base deficit is 5, lactate is 4. negative fast, and he doesn't seem to have any other major head or chest injury. He's placed in a commercially available binder and now has this x-ray, and then he's a transient responder. So what do you think you should do at this point? So again, opportunity to go into the chat and see what you would do. You can respond by letter. So the external fixator, should you go A, B, go to angio, C, go to CT angio, or D, go to pelvis packing at this time. CT angioembolization, okay. So both at the, so they could be different steps. So I've broken them down in 2 steps. So CT angio first and embolization afterwards, okay. Any other responses? Feel free to type in. So it's very rare nowadays that we would put in an external fixator, or certainly an external fixator in the emergency room. The pelvic binders essentially have achieved the same thing that has done. CT angio has some indications, although we'll talk a little bit more about that. Sorry, angiography is B, and embolization has some indication, but we'll talk a bit about that. CTA would be most commonly applied, and this patient isn't in extremis at this point, so I don't think we would go to a packing. So next thing to do here would be to go to CT angio. If their CT angio was positive, and their arterial, meaning there's an arterial blush, going over to angioembolization would be the next step. Now, why do angio? Well, to stop the arterial bleeding, certainly. Being selective in the angio would be preferred. That would be, address the area that's bleeding. Sometimes what the strategy that's used, and previously in the past what had been used, would be a non-selective approach to stop the bleeding generally in the area, both the inflow of the bleeding in a certain area, but also if it couldn't necessarily be identified. There are some downsides to doing angio, and why not do angio, but it's stated it's often not the cause of the bleeding, as from older studies in the 70s that have stated looking at post-mortem studies that 90% of the bleeding was venous. Access to the angio sometimes could be difficult, maybe even the time and to actually get your team together if you do have angio capability. But across British Columbia, angio capability is not available everywhere. So you need to have a solution that still allows you to take care of the patient. So the care setting would be, care setting is actually important. I'll touch on that, and because there might be some unintended consequences of bringing somebody to the angio room. The group in Denver previously published their experience with this when they were previously using angio versus packing, so historical comparison. They found that their mean time to getting the patient who's hemodynamically unstable to pelvic ring injury to the OR was 45 minutes versus over 2 hours with angio. That was a significant finding. The less significant finding, although there is sort of a mean difference, was related to transfusion. Why avoid the angio? Well, one of the tenets of resuscitation is to keep the patient warm, and the angio suite is actually a place in the hospital where it's, the room is purposely cooled to keep the equipment cold. So if you keep somebody in there for an hour and a half, that brings me the concern that if the patient might not be warmed adequately, and certainly not accessed and transfused as well. So angio can work by blocking out a whole area of area's blood supply, which could have consequences. So these are necrotic gluteal muscles being excised from a patient's buttock area. And that's been known since the beginning of the 2000s that non-selective angiography can cause problems with necrosis of the skin. That and having patients lying on their back in the ICU can be significant. So as much as 7% of cases requiring developing this, and 3 of those 12 patients are dying from those infections. So the message is, if angioembolization is going to be done, it should be selective. We're looking at this to try to better inform the discussion. So one of our residents has done some preliminary review of this. He hasn't reviewed all the papers yet, but one of his aims is to look at the complication rate following pelvic angioembolization. And this reports just on 549 patients. We're about just short of 10% complication rate, and most of those being infection after pelvis embolization. Another work that's also in progress by Arish Sperry, who's one of our residents on the call tonight. He's looking at the entire national trauma database for the last 10 years, but if you just look at the last year that where we have the data available, 2018, for 6,500 patients, where about 8% of those had an angio. He identified that undergoing angiography, there's an odds, 4 times odds of developing an infection if you had pelvic embolization. And then looking at this, looking at the additional factors to that were of interest in this analysis, the odds actually came to 2. So it is associated, having embolization is associated with having a higher rate of infection. What about the preperitoneal packing and these other strategies such as the Reboa, preperitoneal packing? So we discussed this, briefly. I introduced that as one of the options earlier. So it's packing is done in the pre-peritoneal space. So very similar to the anterior pelvic approach that you described earlier for your pelvic, for your acetabular fracture. So this gives you access to the area where the bleeders are in front of the sacrum, along the obturator, and in front of the bladder. So packs in that region are usually applied. This is usually done after stabilization of the skeleton with an external fixator, although that can also be done with a binder over the thighs or trochanter if the urgency calls for that. And it can be done fairly quickly. So again, from the group in Denver, they have this on YouTube, where they show you a live, nonstop picture of a packing, which is done. They're putting staples on in 8 minutes and 40 seconds after they started the video. So it's a fairly quick procedure if it's something that's if you're fairly familiar with, and it's something that's being taught now at the definitive DSTC, the definitive surgery trauma courses, which are advanced courses sort of beyond the ATLS, more focused on procedures. So the other, what about Reboa? So one of the options that's come out, and I don't know if that's being used at MAC or elsewhere across the country. So inflating a balloon in the aorta to decrease the inflow in the pelvic region. So we've had some cases of this here. The idea is to have a temporary occlusion. It could be done alone or in combination with packing. I think it needs the right indication, the right equipment, and the right team. And from a guidelines point of view, we had stated at that point that it's still unproven. Risk and benefits hadn't been fully identified, and that the results should be recorded and reported. One of the fellows from Royal Columbian, the other large trauma site in British Columbia, did a systematic review, which we reported on recently at our research day. I identified 12 studies, again, level 3 or 4, but still a fair number of patients. Complication rate was, just over 37%, so a third of patients had significant complications, a lot of them related to kidney function. The mortality, as you would expect in this patient population, if we require Reboa, would be fairly high. Time for Reboa was about just under an hour, length of stay 27 days, and quite a bit of transfusion requirements. So, I think there's still a place for that, something to be considered, but it has to be done, I think, in the right hands, and hopefully people can document their experience well so we can learn from this. The guideline has some measures associated with it. I won't take you through those, but there's essentially part of measuring a system when you're going to develop guidelines of the sort, and just briefly 3 different phases of care for the patients. Whenever I give a talk like this, and I think of, what can you do in the coming week about pelvic ring injuries? First of all, to think if you have your own pelvis protocol, and then maybe call a general surgeon or trauma surgeon at your hospital and ask them, what's the protocol for a pelvis fracture? Set up a meeting with them, general or trauma surgeon, and talk to the emergency room physician, talk to the radiologist. And I think a good test to know if you have a good protocol is if you know the name of your interventional radiologist. So again, if you want to look this up, this on the Provincial Health Services Authority than pelvis. So thanks again for the opportunity to present this.
Thanks, Dr. Guy, for this great talk and shed a light about the guidelines. Actually, most of the hospitals will have some of it, but you guys did a great job by putting it actually in a standard protocol that everybody follow and everybody aware. Multidisciplinary with everybody, general surgeon, trauma team leader, and radiologist. That's great. At least on our side, I know the interventional radiologist name, but I don't think we have a standard protocol as you guys have there.
Well, I think
So-
the idea is just to give some people guidance, and because there are people in various hospitals across BC that won't be a level 1 trauma center and won't necessarily have everything available, or they might not get to you. I don't know. It's pretty densely populated, I guess, in your area, that they can get to a trauma center fairly quickly, I would think. But in some parts of British Columbia, it certainly would take a while before a patient can get to us. So.
By this would take us to Dr. Lefaivre. I have a introduction to have for her talk. I think she's going to present to us about the lateral compression fracture. So go ahead, Dr.
Thank you. Okay. Can everybody see that? Yeah. Hang on a sec. What am I doing here? Slideshow. Perfect. So I guess I'm actually probably touching on the other end of the acuity or severity spectrum by giving just a brief overview of where we are in a particular fracture subtype that's an area of some controversy around evaluation and treatment, which is LC1 pelvic fractures. I do have some disclosures, none of which pertain directly to what I'll be talking about today. So I'll start with a case. This is a fairly typical thing that we see in the wintertime here at VGH as a referral from one of the local ski mountains. So some nice middle-aged person like me skiing at a moderate speed gets cut off by a snowboarder and ends up falling over onto their left side. We can see from this x-ray that they do have an anterior ring injury and some suspicion of a posterior ring injury. And CT scan shows that they do have lateral compression pelvic ring disruption with a complete sacral fracture with some displacement. So what we'll be getting to today is what the options for treatment are in this patient and what some of the evidence is and evolving areas are in treatment of this type of injury. So what I'd like to come away with today is some framework around, which Pierre touched on a bit too, where we are and where we aren't in evidence-based medicine and pelvic fractures in general, and specifically in LC1 pelvic fractures. Some important distinctions about kind of different types and sort of the spectrum of injury around LC1 pelvic fractures. We'll do a brief review of the literature, which will just sort of demonstrate why decision-making remains a bit gray in this injury pattern. Next, we're going to touch on some what's in the toolbox and what some treatment algorithms that have been suggested are, and then I'll give you a brief overview of some ongoing randomized studies in the area. So first, overall pelvic fractures that are bad enough to require surgery have all kinds of long-term problems and lots of important drivers of disability, making studying the importance of specific treatment methods difficult. We published a few years ago a longitudinal study looking at outcomes of B-type and C-type fractures. And we can see, yes, the B-types are better than the C-types, but that at 5 years post-injury, both groups have significant sustained disability. Oops. Historic literature in pelvic fractures has some issues, to say the least. We published this systematic review quite a few years ago now in 2012, but we found that the overwhelming majority of papers published in surgical pelvic fracture fixation used radiographic measurement, but for the most part at that time anyway, don't do a very systematic job of it. They don't tell you how they're measuring displacement, and the reliability overwhelmingly was essentially untested. We decided to take what we found in that systematic review and essentially look at what the reliability of the various suggested methods were. So of the 3 methods we found in the literature that have been proposed for measuring displacement and pelvic ring disruptions, we wanted to test what the reliability was. So if authors are thinking that 3 millimeters or 8 millimeters of displacement is important, we wanted to see whether that was something that was even feasible to measure. And we found, not surprisingly, that overall the reliability is poor. You know, the simplest methods, like the one you can see in the schematic here, which doesn't really leave the reader with any choices, does have fair reproducibility, but doesn't really fit into our current conventional language around displacement in pelvic ring disruptions. Similarly, in functional outcome measures, reporting is really all over the map, making comparisons of different level 4 studies or case series pretty difficult, and doesn't really do a great job of informing treatment. So the quality of evidence in pelvic fracture literature, let's say on an overall basis, is evolving, to say the least. Given that, though, we still are faced with real clinical situations in which we need to make decisions for real patients, such as the patient that I showed you at the start. So when we talk about lateral compression pelvic injuries, really we're making reference to the original description of Young and Burgess, which was published in Musculoskeletal Radiology in the 1980s, discussing 3 different mechanistic groups of pelvic fractures. So anterior posterior compression, lateral compression, and vertical shear. The lateral compression injuries are those in which the internal rotation force causes a compressive failure at the sacrum, LC2 being a compressive failure at the ilium, and LC3 being a windswept pelvis of either type. What they found in this original series, they described it blatantly as a pattern with little resulting instability, although more significant injuries can be seen. And the overwhelming majority of the injuries in this original paper were really just buccal fractures of the anterior sacrum. But for those of us that treat pelvic fractures routinely, we know that there's a huge spectrum of injuries. So there is actually a very high energy variance of these injuries that clearly have a higher degree of instability than the patient you see on the right with a little buccal fracture in the anterior sacrum. With this in mind, we aim to just look at a spectrum of patients with this injury to just describe what the range of injuries was in the anterior pelvic ring and in the posterior pelvic ring. So we looked at a series of 100 patients that have been classified as having LC1 pelvic fractures. We described their injuries in the sacrum as either buccal injuries, complete fractures, fractures or comminuted fractures, and any of those that had fractures that extended from anterior to posterior were classified as complete fractures of the sacrum, which is a language you hear used commonly as it relates to this injury pattern. Other authors have looked at whether or not there's any agreement between clinical surgeons as to which of these injuries need surgical treatment and which don't. Beckman and his group sent out a survey of 27 cases to 111 surgeons, and they considered it to be consensus if more than 90% or less than 10% thought that the patient needed surgical treatment. And they found a very low rate of consensus, really only those at the most significantly and the least significantly ends of the spectrum was their agreement, with a huge gray area in the middle. So the extremes are probably accepted, if not proven, so that the highest energy lateral compression fractures do need some kind of surgical stabilization, and that the lowest energy probably don't. But there's, of course, a huge gray area in the middle, which is where our patient is sitting. Heather Belier and Paul Tornetta have published a lot in this area. And this series of patients, which was over 300 patients with isolated unilateral sacral fractures, of which the overwhelming majority were LC1s. They looked at all kinds of anatomic factors as to whether these informed decision-making across the different centers included. And they really found no correlation between radiographic markers and treatment decisions. So they suggested that this thereby posed a significant opportunity to develop research and consistent indications for treatment. This Bovell Award-winning paper from Tornetta's group in 2009 aimed to look at whether or not these injuries develop any degree of late instability. And really this next series of papers highlights why this remains so controversial. So they had 118 patients with LC1 pelvic fractures, all treated non-surgically, and they followed them forward to see if they developed any radiographic displacement with early mobilization. And their conclusion was that this occurred almost never. They had a single patient that they converted to surgical treatment, and the remainder they classified as stable with early mobilization. The very next year at the OTA, a different group presented a paper that really came to the exact opposite conclusion. So nearly the same number of patients, 117 patients with less than 5 millimeters of displacement at presentation. And they found with early mobilization, these patients displaced by their definition, actually almost always. So they found a significant proportion of patients that had complete sacral fractures and bilateral rami fractures displaced. So one has to wonder if this is a different population, we're measuring different outcomes, or whether there's other methodologic differences. In 2014, this group looked at 50 of these gray area. So middle of the row, not clearly surgical, not clearly non-surgical, but intermediate fractures with less than a centimeter of displacement. All were treated non-surgically, and their conclusions were that everybody that didn't have concomitant lower extremity injuries had good or excellent outcomes. So strongly favored non-surgical treatment in these gray area lateral compression pelvic fractures. So needless to say, no clear answers or guidelines available from the current body of literature in support of both the stability and the instability that's potential for these injuries. There's been a large series of publications by Claude Sadji and his collaborators looking not just at this injury type, but other injury types that are major proponents of the concept of examining patients with potentially unstable pelvic ring disruptions with examination under anesthetic. The first of these publications came out in 2011. And essentially, they describe performing a significant number of pre-prescribed maneuvers and acting on any displacement of greater than 1 centimeter. They cite 100% negative predictive value, i.e. if you don't displace under stress, you will not displace or you will not have any measurable late displacement with non-surgical treatment. In 2018, they've published an even more involved algorithms for LC1 specifically. So they describe an EUA of the posterior pelvic ring acting on any displacement of greater than a centimeter with posterior pelvic fixation, and then repeating the EUA. And if there's any displacement in the anterior ring of more than a centimeter, then acting on that as well. Critics of this kind of more aggressive treatment methodology in lateral compression pelvic fractures would question, what exactly you're measuring, where that measurement's being taken, how reliable it is, why a centimeter is the cutoff. Is 9 millimeters okay, but 11 millimeters is not? And can you actually differentiate between those two things? What's the association with function as opposed to radiographic displacement that's difficult to measure at the best of times? And then in my view, probably most importantly, is what's the trade-off related to potential for complication, specifically with posterior pelvic ring fixation and equally importantly, resource utilization. So what about this question about function or pain and mobility, or how whether we can impact patients' actual experience of these injuries dependent on what we pick for treatment? So this study took 63 patients. They did EUA with the typical Claude Sadji indications for surgical intervention. And they found in this unrandomized study They came to very strong conclusions, so strong that they suggested that in fact, these patients shouldn't even have EUA, they should be taken directly to surgical management. They found better pain scores, faster mobilization, earlier discharge, and less use of opioids. Other authors have been unable to reproduce these results. This study from the shock trauma group in 2016 included 158 patients, 107 non-surgical and 51 surgical that were propensity matched. They found no difference in pain scores, no difference in narcotic use, slightly faster mobilization in the surgical group, but not faster discharge from hospital. Similarly, this paper from Heather Valera and Paul Ternetta, did not support an improvement in pain function beyond that early 24 or in patient-reported pain. They found a statistically significant, but what they concluded was not a clinically relevant difference in pain at 24 hours, otherwise no difference between surgical and non-surgical groups. So how I'd summarize all that is to say what we know is probably a lot less than what we don't know. LC1 pelvic fractures are a huge spectrum of injuries. There's little to no overall consensus on treatment in this middle gray area, with exception at the extremes. Treatment has an unclear impact on functional outcome, may have some more impact on radiographic outcome. And there are some potential benefits of surgery that have been cited by multiple authors, including radiographic, early mobilization, and pain control. Just a brief word on fragility fractures of the pelvis, of which LC1s are a very common variant. And this is likely, we know this is a different patient population and likely a different injury population. Some authors, including Romans, who's published a lot in fragility fractures of the pelvis and acetabulum, would support really aggressive treatment in elderly patients, actually. Such as surgical treatment in anyone who doesn't mobilize early, regardless of the severity of the posterior ring injury. The evidence to support that stance is really limited, but we as a collective orthopedic community in North America and beyond, would probably agree that this patient on the left needs surgery. We would all agree that this patient on the right, with rare exceptions, needs surgery. So one can extrapolate that, does this patient then also have the same benefits from early mobilization and prevention of medical complications associated with injury in the elderly age group? If we do decide to operate on these patients, there's lots of options. We all know pelvic surgery is almost religion-based rather than science-based, depending on where you were trained and what school of thought you're from. Posterior fixation, anterior fixation, or both. This can be percutaneous in the posterior ring or anterior ring. ORAF usually reserved for the anterior ring and more complex injuries in this population. External fixation of distraction type certainly has a role, as does infix. People always want to ask, and last time I gave this talk, wanted to comment on what you do. This is a scoring criteria proposed by Beckman, in which he proposed that any patients that score higher than 7 to 9 on this scale should be receiving surgical treatment. I don't know if that cutoff is actually rationalized with any evidence, but I would say the markers of injury severity and potential for displacement are true. So more sacral displacement, more central sacral injuries, comminuted sacral injuries, and parasymphyseal superior ramus fractures seem to have the highest rate of instability. We also want to think about injury and patient factors. So initial displacement, as I said, markers of instability, although I don't personally use EUA. Injury severity, in which maybe early mobility has a real benefit in some populations, and then in rare instances, the failure of conservative management. In my personal hands, although admittedly non-evidence-based, this is percutaneous whenever possible, and when not in the anterior ring, the infix is a nice, well-tolerated option. So the patient I showed you at the start did have surgical fixation just with a single screw in the posterior ring. This was not my case actually, but by a report from the patient's records, this patient did well. So just in summary, the takeaways, as I said, is that this is a spectrum of injuries with little or no consensus. Treatment has unclear impact on outcome, but there is definitely some potential benefits to surgery and hopefully some emerging evidence coming forth. 2 studies to highlight that are ongoing in the UK. So the first is the LIFE study, which is a randomized controlled trial looking at lateral compression pelvic fractures in patients over the age of 60 that are randomized if they've been unable to mobilize after 72 hours. The surgical treatment arm is infix, and the control arm is non-surgical management. And they're looking at quality of life and cost effectiveness, and they're currently enrolling for this study. The other study, they call the TULIP study. This is in all adult patients with complete sacral fractures that are 16 or older. They're looking at surgical versus non-surgical treatment, which is less prescriptive as far as the surgical treatment. They've just completed the pilot for this and are hopeful on starting the broader enrollment in the coming year. So thank you all for your attention, and looking forward to seeing hopefully some more evidence emerging in this common injury in the next coming years. I'll just unshare my screen maybe so we can see each other.
Right on. Thanks, Kelly. That was a great talk, and really 2 great talks back to back on the spectrum of what we see in pelvis and different aspects of care, and really highlighting, Kelly, your talk was great in terms of highlighting a lot of the vacuum of evidence that we're trying to make decisions around. And Pierre, I think it's interesting to think about the level of evidence you guys have available to you, and when you're constructing these guidelines, how we recommend treatment to centers that are dealing with these injuries that just need some guidance. So, I mean, sort of maybe tying those 2 concepts together a little bit, given how common LC1 injuries are, and say we're getting into situations where potentially we do see a benefit with some surgical stabilization, maybe with some geriatric type patients, or common injuries that might be seen in the community. Should these then subsequently maybe be sent to a level 1 trauma center or a center that does pelvic fixation, or should we be training surgeons in those centers to potentially do some of these interventions? Or does that just underscore the importance of not doing anything in these patients?
Yeah, that's an interesting question. I mean, honestly, I've on the OTA research committee looking at grant applications. There was a study funded in North America looking at this question too a few years ago, and that was the first thing I thought is, wow, if this study shows a significant benefit for elderly patients with LC1 pelvic fractures, that has a huge healthcare cost system level implication. So I think if either or both of these studies have strongly positive findings, there's going to be some clinical scrambling that will be happening right away. The interesting component too will be, with all of these studies, we always wonder about enrollment bias. And these studies will surely be plagued with what many of the hip fracture studies are plagued with, I think, which is sort of rudimentary markers of patient factors. So, a patient's, what's the word I'm looking for? Not just their medical comorbidity and so on, but yeah, exactly. So what their overall, functional status is, because I think at times with these studies, there is certainly an enrollment bias towards patients that are higher demand. So it becomes, it becomes difficult to apply them across the board to a broader elderly population.
Do you know if they're applying any fragility scores or anything along those lines, or? I
don't think the UK study is. And I don't know actually what the status of the study in North America was. That was Mike McKee, if I remember correctly, who was the author of that grant, but I'm not sure what the status of that study is.
So Herman, to the other part of your question, which related to should they be transferred to level 1 trauma centers, Like any operation, I think it requires people to have the, skill, the team, the environment to carry out this type of work. Of course, if you're talking about a, huge number of cases, we have to adapt from a system point of view. But it's not yet a routine operation, placement of iliocecal screws. It does come with complications in the elderly population, and actually the purchase won't be as good. There'll be all sorts of other factors that are important there. So I think I'm concerned actually that if it does show some positive effect, that all of a sudden the people will be carrying out these operations and not necessarily with all the training required. So
I think the candidate age start from 60, which is give you a great, so a larger population number, like 60, considering their study as an elderly. I don't think it's applied here. So they're going to be a bias with that number. Like 60 here going to be much functional.
Yeah,
Yeah,
that's the issue with using age as a proxy for functional demand and sort of vigor. It's depends entirely on the person or the population. So
now, I mean, just thinking about what we're trying to accomplish when providing stabilization to these patients, I mean, so depending on the fracture, ultimately, initially it's hemodynamic stability, but, are we trying to get these patients to mobilize, like the examples we think of in geriatric patients, think about hip fractures and some of the other fractures that immobilize these patients? Are we trying to get them up and walking, and where should that play a role in decision making?
Yeah.
Well, I think that is the focus on the elderly research, is the effect not on radiographic instability or ultimate radiographic outcome, which is so commonly used as a proxy in other adult patients, but on early mobilization, such that patients really have to fail early mobilization to qualify for that study. So that's really where, I guess, where the real impact will be. But again, all those issues around, as Pierre was saying, around complexities of fixation and stability of the fixation in osteoporotic patients. If everyone's full weight bearing on single iliosacral screws, you also wonder if there's some downsides to this as well. I think the findings will be really, really interesting.
I think it's one thing. Kelly highlighted we drive to mobilize patients with hip fractures early and get an operation that's done, and then maybe that falls within the spectrum. But the contrast is, as opposed to having 30 or 40,000 hip fractures in Canada, and it's an expected part of your residency training as you graduate, you caring for a hip fracture patient, putting a stable construct or implant in there, that's expected, and you will have had the volume. That's not the same for pelvic ring injury. So somewhere, if that is something that's a benefit, the training or the referral of patients will have to match.
I mean, I guess that's why they're looking for these increasingly, fractures we think of as unstable, and trying to find indications that there is some reason to fix them, give some more experience.
Yeah, I mean, the other side of it is actually the reality of the decrease in major trauma patients, right? So cars are safer. I mean, there's more people on bikes. That seems to increase our case volume, but in more older people on motorcycles. But overall, the major trauma in Canada, in the developed world, is decreasing because of all the additional engineering developments that have occurred. So. Yeah,
I guess we have the Tesla and the self-driving cars to thank for that too. But there's more scooters coming out, as Kevin's pointing out. We call them the Hamilton Harleys here. We see all these electric scooters rolling around. Subsequently, that seems to be a mechanism of injury for a lot of our patients coming in.
E-bikes have been.
Yeah, exactly.
One final question, I guess, for me, if nobody else has anything else that they want, that's burning a hole in their mind. But we're seeing a lot more research come out around navigation, 3D CT, intraoperative CT, that kind of thing. Potentially as an extension, or again making it safer to do these procedures if they are going to become something that is more commonly done. Are you guys using any of that in BC, or experimenting with any of that, like the O-arm or intraoperative navigation for any of your fixation? Or
so, I mean, it's interesting. Well, in many ways, personally, I've reserved that for more complex cases, revision cases, and navigation. The issue with navigation in the acute setting is that there are two steps. There's in the care of our patients with pelvic ring injury is reduction and fixation. So us relying on the initial CT scan from the emergency room, the environment or the alignment of the fragments will change between the two. The time you're in the OR and the time you're happy with the time you're in immersion, the time you're happy with the alignment. So that's an additional step that makes it a bit more complicated. And it's actually, I would say, an interest of ours because Dr. Lefaivre and I are doing some lab-related work tomorrow on that. So,
Very cool.
Yeah, it's interesting question, Herman. I mean, I think so. Our spine group are heavy O-arm users, so we do have a lot of expertise around that piece of equipment in our system. So I too have used it at times, not for navigation, but sort of more as a rudimentary intraoperative CT. As Pierre said, the difficulty I think with using it routinely is sort of twofold. Is number one, you have to have some mechanism in place, of which the STAR pelvic reduction frame would work great for this. And we have spun the O-arm over it in past. Something in place to hold the pelvis rigidly solid for the navigation to be correct, right? Because the position of the pelvis has to match your initial spin. And then the secondary component is that the instrumentation for the navigation is not designed for the long wires and other components that we use for posterior pelvic fixation. It's all designed for pedicle screws. So for that to really be functional in a broader sense for pelvic surgery, there's going to need to be some new generation of instrumentation that's pelvic specific, I think.
Gotcha. So, I mean, it's interesting to think about the spectrum of research happening in this area, and a lot of it is really technologically advanced when we still need to figure out some basic decision making around it. So it's
good point.
But it's interesting to think about because a lot of us are on the panel here do pelvis, and we like these fancy new gadgets and tools, but we think back to the basics of just it's going to be used in such a select few hands. How we really have to focus on.
And then so just back to that, so those select few hands will get a tremendous amount of radiation every time they carry out those procedures. So a little bit of the driver is that as well. So can we identify strategies that allow us to reduce our radiation exposure? We're very radiation dependent in fracture surgery, right? And increasingly so. That the less invasive we get, the more radiated we get. So let's be mindful of that as well. So.
Well, I think that's a really great closing thought to leave people with and think about as we go forward into our practices. And, if there are any other remaining questions or if people think of something after the fact, I welcome them to email us and we can make sure it gets through to our panelists. I want to really, thank Dr. Guy and Dr. Lefaivre for your time and for reaching out to and supporting the program here. I think it's been great to hear from all of our experts across Canada, and thank you for sharing your expertise with us tonight. Jamal and Dan, thanks for your participation in the panel and moderating. And thank you everybody for attending. And I want to again remind you guys to log into COA next week, and then we have a final session of our trauma nights just to follow and wrap up some cases and hopefully get people applying some of the knowledge they've heard over the last 12 weeks. So thanks again, everybody, and thanks to the panelists for joining tonight.
Thanks. Good night.
Thanks, everybody.
Thanks.
Thanks.
Okay.